Hello and welcome back to my YouTube channel. Today's video will be on chronic lymphocytic leukemia, which will be last in the leukemia series. So let's get started.
Chronic lymphocytic leukemia, or CLL, is a type of slow-growing leukemia which affects the mature lymphocytes, mainly the B lymphocytes. It occurs mainly because of genetic mutations. The risk factors associated with CLL are a positive family history, exposure to herbicide like Agent Orange or certain insecticides, exposure to radiation like UV rays, or monoclonal B lymphocytosis. It's more common in elderly with the age more than 60 years. Male to female ratio is generally 2:1. The patients of CLL are generally asymptomatic and are detected when complete blood counts are done during routine checkups. The symptoms and signs include mainly the B symptoms, which are fever, night sweats, and weight loss. Patient can also present with lymphadenopathy and splenomegaly. Richter syndrome is an aggressive histological transformation of CLL, most commonly to diffuse large B-cell lymphoma. Coming to the diagnostic workup of CLL. In CLL, the complete blood counts show increased total leukocyte count with lymphocytosis. The hemoglobin and platelets are generally low. Most often, the absolute lymphocyte count is more than 5,000 cells per microliter of blood. The peripheral smear will show presence of smudge cells or smear cells. The bone marrow aspirate is hypocellular with more than 30% of mature lymphocytes. On flow cytometry, the CLL lymphocytes express common B-cell markers like CD19 and CD20 with abnormal expression of surface markers CD5 and CD23. Molecular tests like PCR or FISH can be done for detection of cytogenetic abnormalities like deletion 13q, deletion 11q, trisomy 12, deletion 17p, deletion 6q, etc. Coming to the clinical staging systems. There are two common clinical staging systems, the Rye and the Binet staging system. According to the Rye staging system, the CLL has been categorized from stage 0 to stage 4. The stage 0 is characterized by absolute lymphocytosis more than 15,000 per cubic millimeter without lymphadenopathy, hepatomegaly, anemia, or thrombocytopenia. Stage 1 is characterized by absolute lymphocytosis with lymphadenopathy but without hepatosplenomegaly, anemia, or thrombocytopenia. Stage 2 is characterized by absolute lymphocytosis with either hepatomegaly or splenomegaly, with or without lymphadenopathy. Stage 3 is characterized by absolute lymphocytosis and anemia, with or without lymphadenopathy, hepatomegaly, or splenomegaly. Stage 4 is characterized by absolute lymphocytosis and thrombocytopenia, with or without lymphadenopathy, hepatomegaly, splenomegaly, or anemia. According to the Binet classification, there are three clinical stages: clinical stage A, clinical stage B, and clinical stage C. The clinical stage A is characterized by no anemia or thrombocytopenia and fewer than 3 areas of lymphoid involvement. Clinical stage B is characterized by no anemia or thrombocytopenia with 3 or more areas of lymphoid involvement. And clinical stage C is characterized by anemia and or thrombocytopenia, regardless the number of areas of lymphoid enlargement. Coming to the treatment part of CLL. Well, CLL treatment focuses on controlling the disease and its symptoms rather than an outright cure. In those patients who have minimal symptoms or who are not symptomatic, watchful waiting is generally appropriate. The treatment options are mainly chemotherapy, radiation therapy, or bone marrow transplantations. Symptoms are sometimes treated surgically. For example, for an enlarged spleen, splenectomy can be done, or for enlarged lymph nodes, radiation therapy can be done for debulking. Combination chemotherapy regimens are effective in both newly diagnosed and relapsed CLL cases. A combination with fludarabine and alkylating agents like cyclophosphamide produce higher response rate and longer progression-free survival rate than single agents. Targeted therapy. The targeted therapy attacks cancer cell at a specific target with the aim of not harming normal cells. The targeted drugs used in CLL include BCL2 inhibitor, tyrosine kinase inhibitor, inhibitors of some form of the enzyme phosphoinositide 3 kinase, as well as monoclonal antibodies against CD20 like rituximab, etc. Coming to the prognostic factors of CLL. Clinical stage Binet A and RI 0 have favorable prognosis. However, Binet B and C and RI 1, 2, 3, 4 have an unfavorable prognosis. On bone marrow biopsy, if the infiltration is showing a non-diffuse pattern, the prognosis is favorable. However, if the infiltration is showing a diffuse pattern, the prognosis is unfavorable. The WBC count less than 50,000 has an favorable prognosis. However, if it's more than 50,000, it has an unfavorable prognosis. The percentage of pro lymphocytes in peripheral blood, if it is equal to or less than 10%, it has an favorable prognosis. However, more than 10% has an unfavorable prognosis. The lymphocyte doubling time, if less than or equal to 12 months, has an favorable prognosis. However, if it is more than 12 months, it has an unfavorable prognosis. Serum markers like LDH, beta 2 microglobulin, if are normal, have an favorable prognosis. However, if they are increased, the prognosis is unfavorable. The cytogenetic marker deletion 13q isolated has an favorable prognosis. However, deletion 17p has an unfavorable prognosis. CD38 expression, if less than 30% or equal to 30% of cells, has an favorable prognosis. However, if the percentage is more than 30%, the prognosis is unfavorable. And presence of a mutated IgVH has a favorable prognosis. However, unmutated IgVH has an unfavorable prognosis.
So that was all about chronic lymphocytic leukemia, and we are done with the leukemia series now. If you want me to make videos on your suggested topic, you can mention it in the comment section below. Also, I would like to request you to attend the MCQs posted in the community section of my YouTube channel. That will definitely help you in your exam. Thank you and bye for now.